Hey guys, James Sane. So in today's video, we're going to talk about atrial fibrillation. So this is geared towards either the healthcare professional or also if you're a patient and you want to know more about atrial fibrillation as far as we'll talk about what atrial fibrillation is, some of the problems, two very serious problems that it can present, what's the treatment, a high-level overview, and then sometimes, not always, but the progression of the disease. So for the healthcare provider, if you have a patient going to the cath lab, say for like a cardioversion, how do you talk to them? What do you tell them? And so this is for you, and be cognizant that you're not speaking on a level higher than their level of education. You may be talking to a group of people. Sometimes people are embarrassed to ask questions. So I try to keep things very basic and analogies to help people understand. So this is what I typically tell a patient. So in my instance, they're usually coming in for a cardioversion. So I say, hey, I'm going to tell you a few things about atrial fibrillation and then see if you have any questions about this cardioversion that's coming up. So let me first say that the way the heart normally works, you have 4 chambers to your heart. The top 2 chambers contract, empty blood out, they go into the bottom chambers, and then the bottom chambers contract and they pump blood out to the rest of your body. However fast the bottom chambers go, that's how fast your heart rate is when you check your pulse. Now, with atrial fibrillation, there's 2 primary problems. One is a blood clot problem and one is a heart rate problem. So talking first about the blood clot problem, why is that a problem? Okay, in atrial fibrillation, the top chambers are trying to beat 400 to 600 times a minute. They can't really beat that fast, so they really just sit there and quiver. So instead of contracting and emptying blood out to the bottom chambers, the way they empty out is when they get full, they passively empty out. And so blood clots can form inside the atrium. For the healthcare professional, especially on the left side, there's a left atrial appendage that blood wants to collect and be in there, and clots can form. So you see it more on the left side than the right side. Okay, so back talking with the patient, if the blood clots make it from the top chambers to the bottom chambers, then on the right side of the heart, if it gets pumped out of the right chamber, the right ventricle, it goes to the lungs and will cause a pulmonary embolus or a blood clot in the lungs. On the left side of the heart, if it gets pumped out, hey big boy cat, on the left side of the heart, if it gets pumped out into central circulation, it goes to whatever organ it chooses to go to. The worst place would be the brain, causing a stroke, which is why patients in atrial fibrillation are on anticoagulation, something like Pradaxa, Xarelto, Eliquis, Coumadin. And then oftentimes we're doing a transesophageal echocardiogram to make sure there's no clots, because if we're going to shock you back into a normal rhythm, we don't want there to be clots in the top chambers. Now those chambers are contracting, they can easily push clots into the bottom chamber, and then they go out to wherever it is they go. Okay, so that's one set of problems. The second set of problems is typically a heart rate problem. So usually the bottom chambers, however fast they go, that's what your heart rate is. The bottom chambers are smart enough to say, well, I'm not going to go 400 to 600 times a minute. I can't do that. But sometimes that information from the top chambers gets through to the bottom chambers and they try to keep up. And now they're beating 160, 70, 180, 190 beats a minute. Well, most people can't tolerate that. Most people will pass out. And so you may be on medication, you may be on antiarrhythmics to try to stop the rhythm. You may be, the antiarrhythmics can also slow down. You may be on medication to slow down your heart rate. But sometimes the challenge is the medicine then makes the patient's heart rate go too slow. And then your heart rate's 30, your heart rate's 40. Well, a lot of people pass out for a prolonged period of time if their heart rate's 30 or 40. So that's the 2 set of problems. And then you may back off the medication and the heart rate's going too fast again. So we'll get to that in a second. So talking about atrial fibrillation, why does it happen? Well, there's a number of different reasons, and sometimes there is no good reason. It's just, lucky you. It's your genetics. And so typically patients And also patients sometimes know when they're in atrial fibrillation, and oftentimes they don't know. They can't feel, they can't tell. Now, if their heart rate's racing or skipping beats, or people are generally aware of that. And atrial fibrillation, because you lose 25% of your cardiac output, it makes a lot of people feel run down or tired. But some people aren't aware that they're in atrial fibrillation. And so sometimes with atrial fibrillation, patients go in and they come out of atrial fibrillation on their own. And then a next step in the progression, and it doesn't always have to progress this way, it can go this way. Sometimes patients go into atrial fibrillation and they need medicine to get them out. And the medicine converts them back into a regular rhythm. And then as it progresses, sometimes people go into atrial fibrillation and then the medication doesn't convert them back to a regular rhythm. They have to be shocked, a cardioversion, to get them back into a regular rhythm. And then sometimes even like we shock patients and it works, and then it lasts for a year and they have to be shocked again. Or sometimes the time in between people getting shocked gets shorter and shorter. It's like, well, we shocked you, and then a week later you're back in atrial fibrillation. And that's when you get to the point where, well, we may change your medicine, try shocking you again, and you may get to a point where that doesn't even work. And then, so another choice is something called an atrial fib ablation, which is done in the cath lab in the EP electrophysiology lab, where you do electrical mapping of the heart. You try to find where that abnormal impulses are coming from, and you try to burn out through heat or cold to treat the atrial fib that way. It has usually like a 85% success rate, which means it doesn't work 15% of the time. And because I'm going through this, that doesn't mean that this is how everybody's atrial fib progresses. Sometimes people have atrial fib and then they come out of it and they're never in it again. But oftentimes this does happen to people. Now, you may be aware of a point, well, we can't get you out of atrial fibrillation. So no matter what we do, the medication, the shocking, but we can control your heart rate. So you'll be on anticoagulation and you'll be on medicine to control your heart rate. It's those people that you try to control their heart rate, then they go too slow, and and then they're getting into trouble, passing out, and then you back off the medication. Now the heart rate's going too fast, they're passing out. Very dangerous time to drive, by the way. You shouldn't drive. So those patients that you cannot get their heart rate under control, you're going to be on anticoagulation, for the rest of your life, but now you have a heart rate problem. So then there is a procedure called an AV node ablation. This doesn't fix anything as far as it relating to atrial fib, doesn't correct the underlying rhythm, but it just disconnects the electrical connection from the top chambers to the bottom chambers. The top chambers usually set how fast the heart rate is going to be, but you disconnect top from the bottom chambers, and now the bottom chambers are in control of how fast your heart rate is going to be. Well, their intrinsic rate's only about 30. So now you're pacemaker dependent. So if you have an AV node ablation, then you have to get a pacemaker put in, and then you're a pacemaker dependent patient. So while that may be a little confusing, there's an atrial fib ablation that tries to eradicate the cells that are causing the atrial fibrillation, and the AV node ablation, which just disconnects the atrium to the ventricles, and the atria can no longer impact or influence the heart rate. So I hope this helps in your understanding of atrial fibrillation and some of the treatments, as far as why you're on anticoagulation, why the antiarrhythmics, the cardioversions, the atrial fib ablation, the AV node ablation. And as a patient, hopefully this will help you understand. If you're a healthcare provider, hopefully this helps in ways that you can explain to the patient what's going on. Most patients, they want information, good or bad, and they want to be informed. All right, guys, thanks so much. If you liked the video, hit the thumbs up. It would help my channel. And if you found the information helpful or useful, consider subscribing to the channel. And if you do, remember to turn on notifications so that you don't miss when the next video comes out. All right, guys, thanks so much. We'll see you in the next video.